G'day, I'm Graham. I'm going to go through airway assessment, patient positioning and considerations for RSI. So as far as airway assessment goes, we're going to go through the LEMON acronym. So I'm going to start off by looking at the patient externally. Are they obese? Do they have a short neck? Do they have any facial or neck trauma? Do they have any dentures? And are they kyphotic? Moving on to E, we're going to evaluate the 3-3-2 rule. We're going to start off by examining how many fingers we can put vertically into their mouth. This patient currently only has 2, increasing our risk of a difficult airway. The thyromental distance of 3 fingers is pretty smack on there. And our hyoid bone to thyroid notch is very close to 2 as well. So there's a slight increase on the 3-3-2 rule there. Moving on to M, the Malan-Putty score. This mannequin does have a defective tongue, which does impact our assessment here. However, I can see the tonsillar pillars, the uvula, soft palate and hard palate, giving us a score of 1 because the tongue is defective and has fallen backwards. Now we can look for obstruction and look for the history from the family as well. So we're going to look for signs of tumours, epiglottitis, or recent neck surgery. On inspection, just going to use the laryngoscope. If I can't see any gross swelling, gross secretions in the airway there, I can ask the family regarding the prodrome and his medical history as well. Moving on to N, so neck mobility. This patient is non-traumatic, so we are free to move the neck around. There's free movement there as far as flexion goes, and anterior lift as well. There is some restriction in this mannequin for the movement of the neck anteriorly there. So let's move on to patient positioning. What we really want to do is place the patient in a sniffing position, like sniffing the morning air. Ideally, we want to have the tragus to sternal notch parallel. There is some restriction in this mannequin that it does restrict anterior movement, as I said before. Ideally, we want to bring the oral and the pharyngeal axes perpendicular, and we want to lower down our laryngeal axis as well, down towards our pharyngeal axis there. That'll give us an optimum view down into the patient there. So how we can do this, that can be corrected by cushions or towels elevating the head. If there is an obese patient, we can ramp them by putting blankets and towels underneath the shoulders there and then bring the head up. Ideally 30 degrees would be perfect, but we don't work in a perfect world. So I'll just demonstrate with a blanket. So we'll place this on the patient's head there. This is as anterior as we can go. What we want to assess for as well is this patient's face is parallel to the ceiling, which we have a pretty good angle there. Okay. So considerations and indications for intubation. Indications would be your failure of airway maintenance, failure to oxygenate, failure to ventilate, or for therapeutic interventions. Considerations would be your PPE, whether that be eye, oral, and handling. Contras would be no access to surgical airway supplies, ETCO2 failure, pre-arrest or moribund patient, obstructed airway, unless operator is absolutely confident of their success, unable to ventilate with BVM, uncontrolled hemorrhage, and unmanaged chest trauma, or as per their appropriate CPGs. Some considerations would be your pharmacological based adverse events and taking into consideration the dynamics of the patient physiologically. And resources as well. You want to be considering, is my team competent to proceed with this skill? And complications include failure to intubate, misplaced ET where that goes in the esophagus or the right main bronchus, airway trauma, aspiration, raised ICP, critical hypoxia, and even pneumothorax.